Thank you all for joining us tonight. We are going to begin the program in just a moment for National Spine and Pain Center's webinar series with our moderator, Dr. Peter Statz. Thank you all for joining us tonight for the National Spine and Pain Center's webinar series. This is the second session in our series, and we will now begin with our moderator, Dr. Peter Statz.
Well, hello, everybody, and thank you for joining after a long day of work. I know how hard you all are working, and I'm sensitive to your time. This is the second of our webinar series, and the last one was just a week ago. And I don't plan on having these every week, but I thought for the first couple this would be appropriate. We are going to continue an excellent educational discourse tonight with Anish, Lewis, and Ramzan, talking about various aspects of spinal pain and how we can help. A second important aspect of what we're doing is trying to get everybody to know the physician leadership and the leadership in general at the National Spine and Pain or the combined NSPC Prospera group. And tonight we're going to have an ongoing discussion with our president, Mark Coleman. And Mark's going to give us some thoughts, and we're going to do it kind of as a Q&A. I hope you got the questions in advance, Mark, that I sent you, and I hope they're okay. But we're going to be talking about important topics. Our next webinar is going to be October 20th, and then we'll probably pause for about 3 weeks before we start back in again. And that was really timing with elections and things like that. So, you know, I'll be sending out some information on what the next topics are, and be sure to join in. I think it's going to be a valuable experience. On both sides, NSPC and Prospera, and you're going to hear me stop saying the various sides anymore because we're now one big group. But particularly to the Prospera side, I would love it if you guys would email me topics you would like to speak about. I don't know some of you as well as I know others, and areas that you're interested in and where you would like to be up with getting some on the panel here, getting your own NSPC backpacks. So with that, I'm going to start our conversation with the introduction of Mark Coleman. And the title that we gave Mark is a little bit broad, and what can we learn from each other? But I really wanted the faculty and everybody out there, practitioners, to get to know Mark and what his thoughts are about our practice and his direction for where we're going. So with Mark, let me just start with welcome. Thank you for joining the Lion's Den here and having some questions.
Okay, as long as it's not presidential debate style, I think I'll be okay tonight.
Yes, that means I can't interrupt you when you're talking, right?
No, and I promise to not lodge any rude comments. But yeah, this is great that we've been able to meet in this format, and I thank you, Peter, for setting this up and really spearheading this mechanism for us to get a little traction in the area of physician alignment. It is so important for us to begin the process of integrating this very large interventional pain management platform, and no better way to do that than around our shared interest, which is taking care of patients in the most innovative way. So with that, I'm going to let you go ahead and shoot, and I'll answer the questions the best I can.
All right, so here's the thing. For everybody out there listening in as well, you can go to your chat box, and I will find the chat box, and I'll be looking over for questions and answers and try to feed some of your questions in. But I'm going to be limited on time because we have 3 great speakers as well. But so Mark, we just merged with the 2 largest pain practices in the world, I believe, and now we're, you know, definitively the largest. What do you see as the future, and what's the vision for the next step?
Well, I look at it in three phases, really. The first being consolidation, integration, the second growth, and the third being evolution. Okay, and right now we're really in the consolidation integration phase. We take a big deep breath after we sign the papers and all the legal work is done. But then there's the long process of consolidation, figuring out what are best practices from each side and trying to figure what those are, and starting to integrate those. Okay, so some examples of that will be, for example, workers' comp pharmacy. In some states, workers' comp pharmacy is a benefit that can be enjoyed in-house with an in-house pharmacy, and in others you can't do that because of the varying state laws. We have mail order pharmacy in some states where we don't have in-house workers' comp pharmacy, and the merging of those two platforms so that they mutually overlap so that we can benefit all workers' comp patients is one of the things that we're looking at. Lab services. And we're strong in some states with respect to lab, and in others we're not. And in areas where we can overlap, where we don't have a lab, where we're sending out all of our samples to outside labs, we're taking advantage of that. And you'll be here, everyone will be hearing more about that. On the clinical side, there are various different procedures that are done in some areas and that aren't done in others. And we're sharing clinical knowledge. We have a cadaver lab that is going to be put on in Orlando, Florida, where myself and Vip Mangle will be showing folks the Vertos mild procedure, which is a percutaneous decompression procedure, and an open indirect decompression infusion procedure called the Aurora Zip. Many may be unfamiliar with those procedures, and we look forward to teaching others those procedures so that we can affect the best care. After doing integration, we look to growth. Okay, so because we are still a growth platform. The merger roughly took us from about individually about $32 million in EBITDA on the NSPC side, and about 10 million on the Prospera side, to a combined 42. Okay, and we're looking to move beyond that with additional tuck-in, and after we do the tuck-ins, we'll be looking for further transformative add-ons as well. So growth will be the next phase. Longer term, we're going to be looking for really evolution of the specialty. As many may know, musculoskeletal care is a very high ticket item in the United States. And in the United States, we spend more on healthcare than any other industrialized nation. With the advent of minimally invasive procedures, we've seen kind of a dovetailing of some of the neurosurgical procedures for decompression and some of the interventional pain management procedures. And we will very shortly be adding on some neurosurgical professionals onto our ASC platform. And as a next step after that, very likely be adding orthopedic surgeons as well. We have a large pool of patients that are sitting in our nurse practitioner services who maybe are not ready to have their knee surgery or their hip surgery. And we've been giving them pain medications month over month in a chronic custodial care model. Wouldn't it be great if we had the in-house orthopedic expertise to send these patients for evaluation to see if there's a better way that we can treat these patients and perhaps lower the overall opioid count and deliver more efficient care. So that's the type of model that we're looking at going forward.
That's great. I mean, I suspect that by bringing in some new specialties in-house, we'll also be able to do something that you've not talked about, which is really capitate the care, capitate musculoskeletal care, and go to the insurance companies and say, we can take care of your overall healthcare costs of a musculoskeletal patient in a way that we can't do today.
Right.
So I would also say that we've not really actualized it so well yet, although Jock is really starting the process for us to start to improve reimbursement based on our breadth and our size. I think there's going to be opportunities for some appropriate billing structures for us to try to capitalize on our growth.
Absolutely. We're really blazing a new trail where there really, wasn't one before. So it's a matter, we're limited by our own creativity.
Yeah.
And, I think that the world is really looking for something new with respect to musculoskeletal care. And, who better to bring it than National Spine and Pain?
That's great. So I look ahead and I see some rocky roads ahead as well as some challenges ahead. You think about COVID and what's happened with COVID. 10 million people have lost their jobs and accordingly lost their insurance. So that's going to be one of our areas. But I also was on a call today with what's called the Survivor Corps. And the Survivor Corps is the largest network of patients who have survived COVID. And the leaders of this group and I were talking today that pain is actually a really big problem that people haven't figured out. So I've just thrown those concepts out there because I think COVID's going to be a double-edged sword for sure. People are worried about coming in. They're going to have lost jobs and insurance, but there's also going to be even more of a need for us. Mental health issues and opioid misuse have gone up during this crisis. So your thoughts on COVID?
Well, I mean, let's talk about, where we were pre-COVID. Both sides of the company, the integrated company, were on positive trajectories going into the first quarter of 2020. COVID hit, and not only did our in-person volume drop, but our overall procedure volume dropped as well. On average, we went down to about 30% procedure volume at trough and about 50% overall visit volume. Much of that was made up by telemedicine. And at its peak, telemedicine actually made up for the overall volume loss as we moved into the months of late April, May, and going into June. Now we're starting to see that telemedicine is dropping off. I do think telemedicine, to a certain extent, is here to stay. I do not believe that it's going to be a mainstay as we find better and better treatments and potentially a vaccine for coronavirus. But that being said, no one can predict, what is going to happen this winter with coronavirus. And NSPC is very well equipped to deal with any potential outcome of coronavirus, going forward into the winter and into the spring.
So I'm actually looking over the CME questions, and I didn't hit on something that I think is important to be covered here. And I hope I'm not cheating, but there are a number of advantages to our practice. We've talked about leveraging size for an enhanced insurance contract. We've not really talked about some of the other cost savings by having one CEO, not two CEOs, et cetera. Do you see any advantages with vendors, savings, et cetera?
Oh, well, that's already started. One thing that we went into the merger with, at least on the NSPC side, is a very favorable bundle contract with Medtronic, using Medtronic RFA machines and Medtronic leads and stimulators. This is an extremely favorable pricing situation, and to the extent that there may be others on the Prospera side that are willing to give Medtronic a try. I think that there's quite a bit of leverage that we can exploit there as well. We've also gone back to various other manufacturers, for example, Vertos, we're talking to them, Aurora Spine, as we roll that out into to Florida, Georgia, and Texas. We're going to enjoy all of that. Not to mention just some of the cost savings that come along with being on the same EMR, same practice management, having a consolidated IT department. All of those things come down to the bottom, go to the bottom line.
Yeah, and I'd also just say that I kind of look at down the road, and this is probably phase 3. I look at National Spine and Pain Centers as being the Ruth's Chris. So if you go from one place to another place, you can know that you're going to get quality by going to this hospital. And so like Hopkins has set up Johns Hopkins in Florida, and the Cleveland Clinic's got one in Arizona and down in Florida. So they've started to brand hospitals, the expertise of hospitals, and I see that we're going to be able to do the same thing.
Absolutely.
So I've got one tough question for you that I'm throwing at you from our Q&A, and it says, are we going to have training opportunities for mild vertiflex, SI fusion, et cetera, in other states, or are we going to be given the opportunities to go to Orlando or other venues?
Absolutely. Yeah.
So are you paying for it?
Are we paying for it? Well, I will tell you that I'm not going to, commit to paying for individuals at this point, because we're not at the point of integration where we've normalized our CME benefits yet. But for example, Maryland, Virginia, New York, as a part of the employee benefits, there are CME credits and travel credits that each person receives per year. And those benefits can be used to attend, a course. As for course locations, Orlando will not be our last. We will take the show on the road for any and all who want to advance their skills.
That's great. Thanks, Mark. With that, I'm going to end your time, my friend. Feel free to reach out to Mark directly, reach out to me. Again, I am begging you all to send me things that you want to talk about, things that everybody would like to, be up to speed on, or they want to teach on, and for these little webinars that we're doing. So email me at pstotts@treatingpain.com or peterstotts@hotmail.com, and I'll work you into this schedule for the coming months. With this, about 10 to 15% of all low back pain comes from the SI joint. And when I was a mere fellow, we didn't even know how to stick a needle into the SI joint. But now we've got some really advanced diagnostic tools, some more advanced therapeutic tools. And these are now firmly in the domain of the interventional pain doc. So with that, I'm going to turn it over to your VP, right? Senior VP or some title like that, Anish?
It's hard to remember at these points.
I'll turn it over to Dr. Patel. Dr. Patel.
Thanks. Am I audible?
You're audible.
Okay, great. I'm just making sure I can advance the next slides. All right, so I'm going to try to make this as quick as I can. I want to be compliant with my time and respectful of everybody else's. And like Mark said, thank you, Peter. This is the first time we've had an organized CME set of lectures, which I think is going to be beneficial for all of our providers moving forward. I hope everybody can get something out of it. And as I said, I think there's going to be questions at the end. So if you have any questions, just put them in the chat book, and we will try to get to them at a later day. But I'm going to start out with basic elementary anatomy of the sacroiliac joint, and it is essentially the articulation of the ilium and the sacrum and the largest axial joint in the body. It's important to remember that even though it's considered a synovial joint, most of it, being the top 3/4 of it, is not actually synovial, and the entire joint itself is stabilized by a series of bony stabilizers, muscular and ligamentous tissues, as well as dynamic muscles that are in constant contraction with opposing forces to provide stabilization to that joint. Overall, the surface area of the sacroiliac joint hovers at around 17.5 centimeters square in the average adult, and I guess you can take average adult with a grain of salt. It's probably much different in New York City than it is in one of our Carolina offices, or even in parts of rural Maryland. So let's make sure that we estimate that as an average. And there's a couple articular changes that we see moving forward through time, ranging from it being a relatively flat and opposed joint up until puberty, and then showing some beginning changes of degeneration as far as some ridging on the iliac surfaces. When we get to about 50 years old is when you start experiencing erosion of these surfaces and ankylosing of the actual plates. As far as sacroiliac dysfunction, there's a number of risk factors, and sacroiliac dysfunction can be described as any degenerative condition of the joint that results in low back pain. And as Peter alluded to earlier, about 15 to, I would say, even up to 30% of low back pain in the outpatient setting can be attributed to sacroiliac pain, even though we tend to focus more on the lumbosacral region and the lumbar spine as opposed to focusing on the sacroiliac joint. But this should always be considered as a differential in most conditions with any of your patients that have low back pain. The risk factors, and this is not a complete list, but I think the most common list is at the top: lumbar spine pathology or surgery, with all of us see probably on a daily basis; pregnancy and vaginal delivery; direct pelvic trauma; and iliac bone grafting or harvesting for any number of conditions. And ultimately, the treatment of this has been pretty standard for some period of time. I know Peter said during his fellowship in 1937, they didn't have sacroiliac joint injections, but most of us in the common new world today have probably been well trained in doing sacroiliac joint injections, and even to a point, radiofrequency nerve ablation. But arthrodesis, of which there's open and percutaneous, I think is a relatively new phenomenon to most pain management specialists. It's been open to surgeons and our surgical colleagues for some time, but was never really marketed to the pain specialists who, in all reality, are probably the interventionalists who are most common seeing a lot of the sacroiliac dysfunction. I'm going to move on to pathophysiology now and just quickly run through this slide. The most common, as far as I'm concerned, is the fourth bar down, showing osteogenic, implying spine surgery, arthritis, ankylosing spondylitis, but a number of other conditions can lead to sacroiliac disease, including metabolic disease such as hyperparathyroidism, gout, renal osteodystrophy, acromegaly, all the way to tumors, certain infectious agencies, and of course, direct trauma to the pelvis. The presentation of your average patient is going to be back pain, and back pain can be present with pain isolated to the back, unilateral, possibly radiating to the opposite side, bilateral, as well as occasionally up in the groin, or just superior to the groin area, in the lower quadrants of the abdomen, albeit much rarer. It does tend to occasionally mimic radicular type pain, in that you can see pain radiating into the buttocks and posterior thighs. I wouldn't say this is common, and often we try to use that as a differentiator between radiculopathy and sacroiliac pain. But please bear in mind that just because somebody has radicular pain, it doesn't rule out necessarily sacroiliac joint pain. A lot of patients will describe the feeling of instability, buckling of their hip, or giving away of their knees, and usually that's a pattern of pain, not so much actual weakness being relayed down or transmitted down to the knees or lower joints. A lot of patients have trouble sitting and have disturbed sleep patterns, and you might often just see this person in the examination room sitting with one leg crossed over and raising that buttock off the chair or off of their seat, and that can often be a very common symptom, common sign of sacroiliac pain that has not yet been diagnosed. Physical findings upon inspection are an antalgic gait or a guarded gait of some degree based on severity of the discomfort. Palpation will show tenderness at the posterior suprailiac spine, as well as the point that we call the sacral sulcus. And we'll move on to motion as far as physical exam findings in the next slide. But neurovascularly, these patients should be neurologically intact. If you do see any neurogenic issues, you should probably consider a radicular component and possible spinal involvement, which with or without can be present with any sacroiliac pain. If they do have any weakness, it's usually due to inhibitory responses from pain and not so much from actual neurological weakness. The biggest, I guess, portion of your examination that you should probably be focusing on when you're diagnosing this condition are the provocative tests. And there's a series of provocative tests with varying degrees of sensitivity and specificity. The reason they're important is most of the payers that we're looking at today, including CMS and Medicaid, are going to require some documentation of provocative testing if you choose to do any advanced procedures. And advanced procedures meaning percutaneous arthrodesis or even radiofrequency that we'll get to in a couple of minutes. But these are the hallmark tests for sacroiliac joint dysfunction. And I'm not going to go into any great detail here enumerating each one just to help us stay on track with time. But as you can see, all of them happen to be provocative maneuvers, with the exception of Fortran's finger test, which is essentially just a patient pointing at the sulcus on the backside. When you ask them where is your pain isolated to, they should be able to do it with one finger. Not the most specific test by any means, but does, along with the other 5 tests, help provide you with a good landscape as to whether the patient is actually having sacroiliac joint disease. So if you don't recall these examinations, I would definitely try to brush up on them, because if you're going to consider doing any of the advanced procedures for sacroiliac joints, depending on where you are or what your payer mix is, I'm sure that a lot of these payers are going to require at least 3 to 4 provocative tests to be documented for advancement or authorization for procedures. Identifying the patient. So just to somewhat reiterate, as far as our symptomatology, who you should be identifying and who you feel should warrant diagnostic imaging. And most of these patients are going to have pain history for at least 3 to 6 months, which is not radiating. Your sacroiliac joint examination, as well as your provocative testing, should show positive. And then they should have the absence of a generalized pain disorder, such as somatoform generalized pain like fibromyalgia or myofascial syndrome. Those should be ruled out. Not to say that generalized pain disorders can't be present alongside sacroiliac joint disease, but that should not be used as the diagnostic feature for someone with sacroiliac joint disease in the absence of SI examination or provocative testing. Diagnostic injections, which most of, if not all of us, are performing, I would hope on a daily basis at this point, where we are providing sacroiliac joint injections, sometimes with or without steroids for diagnostic purposes, hopefully can become therapeutic or lead us to more advanced procedures, more permanent solutions such as radiofrequency or arthrodesis. And lastly, diagnostic imaging. When we talk about diagnostic imaging for SI joints, X-ray continues to be the most cost-effective and useful modality for diagnosing sacroiliac joint disease other than your physical examination. Authorization for CT scans and MRIs for sacroiliac joint disease is much more difficult to get authorized, so you need to be focusing on your X-ray examination. And what we'll see are typical findings: joint space narrowing, sclerosis, and osteophytes. Those tend to be the greatest things. So when you're looking at an AP X-ray, or even when you're looking at these patients under fluoro, and you're looking at a contralateral oblique view, you should be able to see a nice, crisp sacroiliac joint space. When that starts to become sclerosed or rough around the edges, you know that you're dealing with varying grades of sacroiliac joint disease. CT scans and MRIs can, of course, be used and will show evidence of sacroiliac joint disease. Most of the time, we're using CT scans if we're considering surgical correction. By no means is that required for any therapeutic interventions. I included bone scan only for the reason that it is highly specific to sacroiliac joint disease. Nobody in their right mind is going to order a bone scan as their initial diagnostic test for sacroiliac joint disease. But by all means, for the nice little old lady or gentleman that's 78 years old that has a history of osteoporosis who may already be getting bone scans, a further examination of that scan at the hip and pelvis should indicate uptake in that sacroiliac joint disease. And if you do see it, it has a specificity of approximately 90%. I'm going to briefly talk about the treatment options in 2 different slides. The first being non-invasive options. And again, for the sake of time, I won't just enumerate off of the slide deck, but we're all aware of conservative care in the form of medication, therapy, and even pelvic bracing. Specifically, trochanteric bracing is pretty useful, and that's when a tight rubber band or an ACE bandage or any very restrictive sort of banding, which goes around the entire pelvis over the trochanteric braces as margins on the sides so that you know you're bracing the right area. And what this is going to do, it's simply going to limit the shear forces and the motion of the SI joint. I don't think a lot of us use that technique. We probably much quicker go straight to medication management, physical therapy, or even injection therapy. But it can be pretty useful, especially in the older population who may not be amenable to more invasive therapies, or for example, someone who's using a walker or a cane. Trochanteric bracing can actually be quite effective for these patients as far as symptoms. Regarding invasive options, we all do corticosteroid injections. I'm sure a good number of us are advancing to sacroiliac joint RFA if permitted by insurance and if learned as a technique. Once you complete diagnostic injections, either with lidocaine, Marcaine, any local anesthetic, or you tend to use that as a therapeutic intervention with the inclusion of corticosteroids. And then the last 2 being minimally invasive arthrodesis and open arthrodesis. Quickly, again, SI joint injections, there's about a 75% reduction if you do a single injection, and this is usually confirmatory of the diagnosis. And the photo in the top left is showing you a fluoroscopic image with contrast material spreading inside the articular joint space. And the lower one is showing the actual photo through superimposed osteopic. And remember, you know, when you're doing fluoroscopic images of this, the best image of your sacroiliac joint is going to be in a slightly caudad manner with a contralateral oblique, which is the exact angle that you're seeing this gentleman do his injection in. Success rates vary. I think 60% over 6 months is probably a little bit optimal in my practice. I don't think that's a realistic number. That's probably higher than what I'm experiencing, but a number of these patients will be relegated or converted over to sacroiliac joint RFA should they get 50% reduction following their injections. Regarding radio frequency, everybody has their own techniques of doing radio frequency. I've seen people actually go at the north and the south end of the actual joint space and drop their needles from the top and the bottom and believe that they're actually getting sacroiliac joint radio frequency. But in reality, you're targeting the lateral branches of the sacral nerve roots. And where you're going to do that is halfway between the exit of the foramen and the articular line. So if radio frequency is something that you've been doing, I hope this is the technique. It's multiple needle. It does take a little bit of time, and you are actually trying to target the lateral branches of the sacral nerve roots, not the same approach that you're going to be using with the interarticular sacroiliac joint injections. The efficacy, again, it's going to be very limited based on your inability to denervate these structures. If you're able to denervate them, wonderful, you'll probably get a positive response. If not, these patients are going to continue to experience some degree of sacroiliac joint pain, might require something a little bit more invasive. The treatment options are percutaneous fixation and open fixation. I'm not going to really discuss open fixation because none of us can or should be doing that procedure. It's a pretty archaic technique used by very, very few surgeons, I think, in this day and age. So most of the surgeons and interventionalists are using the percutaneous fixation techniques, which are gaining more and more popularity. It came in 2 phases. There was a first generation of percutaneous fixation, and this utilized a lateral procedural approach where in some form or other there was the insertion of pins or screws laterally across the ilium through the joint space, actually into the sacrum. The problem with this is that it was not really considered a fusion, even though it was being considered or called a fusion, but it was more of a bridging of the joints as opposed to a fusing. And with any sort of insertion hardware into bony material, you're going to get demineralization at some point and pseudoarthrosis. So this was tend to found even further degrees of instability. So we've more or less abandoned, I think, in most quality centers and most centers of excellence, there's not a whole lot of first generation percutaneous fixation happening with screws anymore because of the reasons that I just enumerated. And also due to the fact that we have much better techniques today to actually perform percutaneous fixation. So now we'll move to the second generation. And this series of slides is just to show you exactly how the procedure is performed. I don't have a lot of photos of the actual kits here because the various companies have various styles of kits, but they all have the same basic elementary technique and procedure. And initially, the procedure starts in an AP view with the addition of a Steinmann pin, which you see in the top left coming through the initial trocar. So the Steinmann pin is usually placed into that sacroiliac joint in the AP view on your fluoroscope, at which point when it's advanced to midway through the sacrum, you will then flip to a lateral view, and you now enter with larger and larger access ports. So the first being a relatively small port, maybe 4 to 5 times the size of the Steinmann pin, and then a larger trocar being advanced over there, which is a working cannula. The third slide on the top shows the insertion of either a reamer or a drill to create the potential space for your actual graft being inserted. And then last is going to show you, with a little bit of squinting, you may be able to see the graft just between those two prongs being pushed through with that small device in the center, the small little prod in the middle, which is pushing that graft through. If you look at the fifth slide very carefully again, you will see midway through that joint space, maybe 2/3 of the way down, actual haziness, which is your actual bony graft, which has now been inserted. The benefit of this device is that you are indeed creating a true bony fusion. There are, like I said, there's a lot of different players in the market today, coming from single pole devices with the insertion of one graft all the way up to bi and tri insertion techniques, all which claim varying degrees of stabilization. But for practical purposes, your advancement in your technique through the procedure is going to look just like this and is going to be very similar. I would tell you that I've probably done about 50 or 60 of these now, and they work extremely well for our patients, and the results have been beyond optimal for a majority of the patients. And I think it's something that all of you should definitely add into your armamentarium. And I think that we've had this included in some of our courses in the past, and I'm sure Mark and Vip will have it included in Orlando and moving forward. This is just my last slide showing the actual generic fixation of a bone graft into the sacroiliac joint. And as you can see, this is a one graft system advanced right through the center, showing the fusion by animation. So with any further ado, I will end my session. Thank you everybody for taking time to listen. I hope this becomes something that's useful for all you in your practices, and have a great night.
Thanks, Anish. Great presentation. And you too will be getting a NSPC backpack. So thank you for contributing and lecturing. Now I'm going to do the next question for people tonight. Is there's no cheating, no cheating. First person to chat me the answer will win. What is the, and you got to spell it correctly, what is the state fish of Hawaii? Okay, so with that, I'm going to turn it over to Dr. Fandos. Dr. Fandos is going to talk to us about percutaneous discectomy. It's kind of gone into favor, out of favor. You know, the original perc disc was done with papain, 100, you know, not 100, but a long, long time ago, and that kind of fell out of favor, and we've got better techniques now. Dr. Fandos was one of those who called me and said, I got a great therapy that we should be talking about. And so with that, I'm going to turn it to you, Dr. Fandos.
Thank you, Peter. I really appreciate having me here tonight. So we're going to discuss percutaneous discectomy. Like you mentioned before, there have been so many procedures all these years that have been in and out and kind of falling out of favor. But I believe that this one is here to stay. And I will explain to you as to why. Next slide, please. So before we, I have no disclosures to make. Next slide. So before we start discussing the procedure itself, I just want to refresh a little bit the pathophysiology behind a herniated disc. So as you know, the disc has two main components, which is the annulus and the nucleus pulposus. So the nuclear material is a highly hydrophilic matrix. And the reason as to why it's hydrophilic is because it allows for an even distribution of the forces into the annulus as they are applied on an axial fashion. So as we live life and we bend and twist and pick up heavy things, this nuclear material starts to degenerate, and the way it does it, it becomes harder. It loses some of the water content. So there are certain parts of the disc that become harder than the others. And this creates two problems. Number one, it increases the intradiscal pressure that puts more pressure on the annulus. And number two, it changes the dynamic on how the axial forces are distributed onto the annulus. So all of a sudden we have now forces applied on one side of the disc more significantly than the other side, creating more wear and tear on the annular fibers. Then the annulus loses the elasticity, and we start having tears, these protrusions, and then finally these herniations. So any procedure that we're gonna use that is going to try to address discogenic pain has to have this in mind. We need to address the increased pressure inside the disc. We need to address the fact that there are parts of the disc that might be hardened and degenerated, and we have to address the annulus that is torn, and also all the fibers that are located on the posterior third of the disc that help to create a great deal of pain when the herniation exists. Next slide. So all these years we have multiple procedures. For those that have been in practice for more than 15 years, like I did, been through many procedures that look like they were the best solution for this pathology, and we used them, and then they fell out of grace. And one of the reasons I believe that they didn't work is because none of them fully addressed every issue of the disc, like I mentioned before. So we, many of you might remember the Stryker decompressor that we used maybe 10, 12 years ago. This device allowed us to decompress the disc by removing tissue, but it didn't address the portions of the disc that were hardened, and it didn't address the annular tears and fibers, nerve fibers of the posterior plexus of the disc. Nucleoplasty was a procedure that it was somewhat effective. I used it in my practice for a number of years until it wasn't approved anymore by any of the insurance carriers. And the nucleoplasty did accomplish two of the three issues of the disc. It did help with some debulking of the disc by vaporizing the disc material using radiofrequency, and also by modulating the annulus. So by diminishing the amount of hardened parts of the disc and stimulating the neoformation of disc matrix. But it didn't address the annular issues. So we had IDET, which was the deployment of a probe along the posterior annular fibers. And by using high temperatures, it would coagulate the tear of the disc and also ablate the nerves of the posterior third of the annulus. However, it didn't address the intradiscal pressures or the abnormal matrix that was in the disc. So with this new procedure now, we're able to do all of this in one, which is tissue debulking, annular modulation, nuclear modulation. It allows for direct visualization, which we'll see in a few minutes why this is so important. And I have added a fourth step on my practice that has been working very well, which is the use of PRP. There's a lot of literature now that talks about the use of PRP for degenerative disc disease. So if I'm going to be doing an intradiscal procedure, it only makes sense that if I'm already removing disc, why not add PRP just to complete the technique. Next slide. So with the percutaneous discectomy kit now, we can do all of these maneuvers that will improve the disc regeneration rather. And it would also allow for irrigation and suction of some of the breakdown materials that are left over inside the disc. We can remove that, and also it allows for documentation, which is really, really important. And again, I'm going to describe that a little later in the presentation. Next slide. So the indications are usually herniated discs that are contained, not extruded discs. Patients with back pain that have either degenerative disc disease, a black disc, and where the herniation is no greater than 1/3 of the sagittal diameter of the spinal canal. Discography is more of a controversial tool. I do not usually use it in my practice. If I have a patient that have 1 or 2 herniated discs and it's pretty clear to me where the source of the pain is, I usually do not use discography. If there's a patient that presents with multiple herniated discs, like 3 or 4 herniated discs, then it is important at that point to try to identify which is the most painful disc, and therefore discography becomes a more useful tool. Patients with plain back pain can be candidates as well, so long there is abnormal findings on the MRI at the disc level. We need to consider facet joint injections on these patients to rule out the facets as being the source of the pain. So then if we have a patient that has back pain, that has a black disc on MRI, that has not responded to physical therapy, medications, and epidural steroid injections, as well as facet joint injections, might benefit from this procedure. And obviously there's got to be a correlation between the patient's symptoms and the MRI findings. For example, if the herniation is on the left side, we want to see pain radiating down the left leg on the same dermathome of the herniated disc. Next slide. So this is a picture of an MRI ideal patient, the one on the left side. You can see a herniation there. It's less than 1/3 of the sagittal diameter of the spinal canal. The L4-5 disc is usually one of the most common ones. As you can see in this slide, also the L5S1 disc is herniated. And again, it's a small herniation. In this patient, we'll probably consider doing both levels. The MRI on the right side shows a herniation, but there is migration of this material into the epidural space, even though it's small. So this might not really be the ideal candidate. These are the patients that would benefit from this are younger patients in their 20s, 30s, 40s, even in their 50s, where there's no significant spinal stenosis, no facet joint arthropathy, that have just herniated disc that is causing significant amount of pain and disability, has not been improved with our usual treatments. Next slide. So this is the description of the tools that we use. We first place a spinal needle into the disc using a 45-degree angle, the same approach as when we perform discography. So anybody that does discography can definitely perform this procedure. Once the needle gets into the disc, we inject dye along with antibiotics to confirm the intradiscal placement of the needle. After that, we place a guide wire that goes into the disc. The needle is removed. An incision of about 5 millimeters is then performed. And then we advance the trephine and that goes into the disc, and we advance a cannula. This creates our working channel to what we're going to use all the tools. First, we're gonna take the grasping forces to do a tissue debulking, and then we're gonna use the trigger flex, which is a bipolar probe, radiofrequency probe, that will allow us to do the tissue modulation. Next slide. This is just a slide that shows the kit as it comes. Next slide. And this slide shows the approach, which is through the Cummins triangle. Again, the patient is, we enter a 45-degree angle. We want to go just anterior to the SAP. The most vulnerable structure here is the exiting nerve root. As you can see on the left upper square. So when we are advancing the tools, we have to be mindful of the nerve root coming out. So if we stay just anterior to the SAP and in the center of the disc, the chances of hitting the nerve root are really low. Next slide. Once we created our working channel, we start the procedure. The debulking of the disc is done with on a forward fashion with the jaws of the grasper open, and then when you withdraw, you pull back, you close the forceps and brings a significant amount of tissue. Next slide. When you go from one side to the disc, you have to make sure you do not damage the annulus on the opposite side, because you will be creating another problem by doing that. Next slide. Usually you're able to take out anywhere from 1 to 2 cc's of the disc, which is plenty. I'm usually satisfied with 1 cc. That's enough to decompress the disc, and also we should be sending the disc material to pathology to confirm that that was disc that was removed, just in case there might be a questioning from the payers, because sometimes that happens. Next slide. So the second part of the procedure, once we did the debulking, is the nucleus ablation. We use a bipolar probe with high intensity radiofrequency that vaporizes the tissue. It helps with the tissue debulking even further, and also it will help to modulate the nucleus material by stimulating the neoformation of new disc. This is somewhat similar to the nucleoplasty procedure. However, the frequencies of the radiofrequency are different, and they appear to be more effective. Next slide. So this is a view of how we perform the nucleus ablation. We go from one end to the other of the disc. Again, we must be careful in not damaging the annulus on the opposite side. And also we try to stay away from the end plates, because that, if we do ablation at the end plate level, that could be significant, very painful, and the patients complain of a great deal of pain after surgery. Next slide. And the third part of the procedure, once we accomplish the tissue debulking and we've done the nucleus modulation, now we're going to do the annular modulation. So it is important for us to always look at the MRI before we consider doing this procedure. We wanted to enter on the same side where the herniation is, and we are going to move the access cannula dorsally, so that we get closer to the posterior annular fibers. And then we place the probe at this level, and we're gonna use a different radiofrequency that it will also ablate tissue, but it's not gonna transmit so much heat, and therefore it will reduce the chances of thermal injuries to the nerve roots and the epidural space. Next slide. So here you can see on the fluoroscopic views how the cannula now is placed on the posterior third of the disc. And on the AP view, it shows how we ablate the fibers on the side where the herniation is. Next slide. Now, there is one step that can be added where it changes the description of the procedure, which is the use of a dilator. We can use a dilator throughout the procedure, and by doing this, it allows us to change the CPT code. As you may know, as you all might know, percutaneous discectomy is not really a procedure that is approved by most commercial carriers. But when you place a dilator, next slide, you can advance this close to the disc and you perform the same procedure I just described, where the only difference is that you are able to directly visualize the disc. So what we do is we use the same approach, a 45-degree angle. We dilate the tissues, get down to the fascia, and then by advancing the dilator close to the disc, we can visualize the disc directly. Next slide. All we need to do is place a light source to the dilator, and now we can perform the entire discectomy using direct visualization. So the importance of this is, next slide, is that it changes the code. So from a 62287 code, which is a percutaneous approach that is only covered by no fault and workers' comp, now we can use 63056, which is the use of a transpedicular approach. So we don't go through the epidural space. We're going transpedicularly, which is exactly going through the Cambian's triangle. And we can perform the discectomy and the direct visualization. And that allows us to use the 63056, which is covered by almost all the commercial carriers. Next slide. So this basically is the description of the two codes. Obviously, it's not a perfect description with the method that we use, but it's pretty close. And like for other things that we use, for example, in DRG, we use spinal cord stimulation codes, even though we're not really stimulating the spinal cord, but we are going through the epidural space. So part of the description of the code it's very similar. And the same thing applies here. So 63056 is the discectomy code. It's transpedicular, not going through the epidural space. It's going a 45-degree angle that is usually indicated for lateral herniated discs. And again, it's covered by most of the insurances. Next slide. And the last part of the procedure is the use of PRP. As I mentioned before, where we are debulking the disc, we are modulating the nucleus, and we're trying to stimulate the formation of new nuclear material. So adding PRP would only make sense by placing all the growth factors and all the materials that the disc needs to start rebuilding the disc from inside out. I used several systems, and I like this one the most. And this is what I use right now, the ICP systems, as opposed to the regular open systems, because it's very quick. It takes only 5 minutes to prepare. It's completely sterile because it's a closed system kit. And it can be prepared by my scrub nurse while I'm performing the discectomy. And it also, it has very low leukocyte or white blood cells, which is reduces the inflammatory process. And as you can understand, patients will already have a lot of pain, and using a rich white blood cells PRP can cause a significant amount of pain in addition to the discectomy pain. So to me, this is the one that has worked the best, and I have been having great results with it. Next slide. So the ACP systems have high concentration of all the growth factors that are necessary to stimulate that growth of the nuclear material, and and this will allow us to now do something that we haven't thought of it before. Up until now, we always consider that if a disc is damaged, it has to be taken out, or it has to be removed, it has to be replaced. This technique allows us not only to maintain the same disc that the patient had, but also to enhance the properties of that disc and help to it heal itself from inside out. Next slide. What are the contraindications? Obviously, any patients with spinal fractures and tumors, infections of the spine, neurological deficits, cauda equina, progressive neurological deficits. Grade 2 spondylos are contraindications, since that's an indication for open surgery, or a grade 1 spondylo that is unstable. So if we have any question of, we have a patient with a grade 1 spondylo and there is we're thinking about doing a microdiscectomy or a percutaneous discectomy, we should definitely consider fixation films to make sure there is no instability at that level. And like I mentioned before, extruded discs or sequestered discs are not candidates for this procedure. Next slide. Potential complications, anytime you enter into the disc, you risk the chances of discitis. I use IV antibiotic prophylaxis, and also I inject antibiotics mixed up with the contrast when I first inject the spinal needle, and this has worked well so far. Nerve root injury, like I mentioned to you before, on the approach, on the 45-degree angle approach, when you're going through the Cummins triangle, the only route that you may encounter is the exiting nerve root. So you have to be mindful of that and make sure that you're just anterior to the SAP and in the center of the disc. And by doing that, you're really lowering the chances of any nerve root injury. Epidural hematoma, dural tears are complications that happen when you're not doing what you're supposed to. You're getting into the spinal canal. With this approach, you're not going through the spinal canal at all. And obviously, allergy to contrast is one of the complications that could happen. Next slide. So the literature has been abundant. There are many papers. Stefan Hellinger is in Germany. He's one of the early adapters of these techniques. He's published a number of papers, and this is a next slide, a prospective study that he did on 47 patients. All of them would contain herniated discs. Back pain reduction was about 73%. Leg pain reduction was 70%. And the overall patient satisfaction was very high, because they were able to accomplish the same results as with open microdiscectomies, with the difference that there is a lot less surgical trauma, and the patients were extremely happy with it because they didn't have to stay in the hospital. As you may imagine, this is performed under local anesthesia with a low sedation and in an outpatient setting. Next slide. There are other studies published. Dr. Kumar published a study in 2018 with 51 patients, 2-year prospective study with the same results, very high patient satisfaction. Next study, next slide, I'm sorry. So there are multiple other case series that were published that all of them with good efficacy and safety profile. Next slide. Same thing here, another study that showed good efficacy. Next slide. Next slide, please. One more. And this is pretty much it. So this technique fills the void in our practice when we have patients that are in their 20s, 30s, or 40s that we have tried all our usual approaches, medications, physical therapy, epidural steroid injections, and nothing seems to be working. It's usually the next step is to send the patient for surgery. And I found that this technique works really well on the younger patients without any significant structural abnormalities of the spine that have contained herniated disc, and it has worked well for my practice. Thank you.
Thanks, Louis. Excellent presentation. And, really, you brought forth something that was kind of a little bit of a forgotten art, and the nuances of how we can actually get paid for it, I think, are really important. So really, really key. And it kind of fell out of favor for me for a while because other than workers' comp and no fault, as you pointed out, nobody was paying for it. So I was glad that you brought this back up and to bring this back to the group as a possibility that might be good for your patients.
Yeah, and again, placing the dilator, it makes it a little bit more invasive because now you're creating an opening of about I would say 1.5 centimeters, but still it's minimally invasive, and you're not really destroying tissue. You're just separating the fibers with the dilator. And it really makes a big difference because now you can directly visualize the disc, and that allows you to build the other code.
Yep. So thanks again. Appreciate it. And Louis, you are going to be receiving one of these wonderful backpacks as well. They're really cool. You get a backpack, you get a backpack, I feel like Oprah here. And another person who gets a backpack is Dr. Keaton Patel. Dr. Patel, I know you can't speak because you're locked out right now, but you were the first correct answer with the correct spelling. So congratulations for that. I have another question that I'll tell at the end of this, of Dr. Benjamin's, and we'll do our final question of the day. And if you have already got a backpack, you can't answer this question, or you can answer it for bragging rights, but you don't get a second backpack. Nobody needs two. But who was the physician who first described using electricity in identifying a peripheral nerve in regional blocks and regional anesthesia? So while everybody's thinking about that, Ramzan already knows the answer. I'm going to introduce my good friend Ramzan. Ramzan and I have been great friends for 25 years, it seems like, and a brother from another mother. One of my heroes in life who's made it from through trials and tribulations to be, where he is today as a leader in the field, two-time ACIP president, guy I turn to for tough clinical questions. And with that, I asked Ramzan to cover pathological fractures and what to do about it. And all three of these therapies 20 years ago were firmly and solely in the realm of the anesthesia of the physicians, the orthopedic surgeons and neurosurgeons. And it's really remarkable how the field has changed and has been improved upon with even the work that Louis was just talking about, adding PRP in, and what does that do for us? Our field is just completely different than it was 20 years ago. So with that, I'm going to turn it back to you, Dr. Benjamin. And let's see who the first answer was. I'll tell everybody who won at the, if anybody, at the next break.
Thank you, Peter. You've always been very gracious to me, and I'm proud to call you a friend. And being in this session means a lot to me. This is the first time in 7 years, 7 months, I'm sorry. I'm coming out of my shell and I'm doing a Zoom meeting. So on that note, I decided to discuss clinical aspects of a treatment that I always call it the most gratifying procedure that an interventional pain doctor can do. And on top of it being gratifying, the recent data has solid evidence of how this procedure has become a life-saving procedure. We don't have those things in interventional pain, as you can tell. Could you please advance? All right, so, all right. as we have been dealing with a pandemic in the past 8, 9, 10 months, it's kind of one of those forgotten epidemics in the world has been osteoporosis epidemic. We have over 40 million people in the United States affected by it. We have over 200 million, and I'm sure the number is even more than that because of lack of good statistics from many of the populous countries. Unfortunately, it does affect women at the ratio of 1 in 3 versus men 1 in 5. And if every over 80-year-old woman walks into your office and you don't think about osteoporosis, you might be missing an opportunity to relieve a life-saving ailment in this patient. So these women over 80 years old, 80% of them are going to have osteoporosis, and 40% of those are going to get a vertebral compression fracture. Now, on the right-hand side, you can see the impact of osteoporosis and fractures, over 2 million a year compared to the heart attack and stroke and even breast cancer. Why are we interested in treating these patients? It's very simple, because once you get these fractures, you have 9 times more chance of dying. And you have more than 50% chance of becoming dependent in your self-care assistance. So compare that to about 8% in those people with low back pain and osteoarthritis. So recent large studies have shown that at 5 years, there is 72% mortality for non-treated osteoporotic fractures, and at 7 years is 90%. Next one, please. Okay, so why is this problem underdiagnosed and untreated? Now, I'm going to focus mostly on the clinical aspects and leave the technical aspects to other experts. Imagine 2/3 of all the fractures are undiagnosed. Why? First of all, when these patients come to you, the history is very non-specific, and they have significant referral pattern of pain. A lot of them, you would think they have SI joint problem or facet pain. So that's part of the problem. The other problem is that as pain doctors, we are so much focused into spine, disc, facet, SI joint, that sometimes we forget about, oh, this patient has history of breast cancer or prostate cancer, and maybe the back pain is a metastatic tumor, or patient has history as a female that is old and Caucasian or Asian and has been on steroids for a long period of time because of COPD, and in the past has had wrist fracture or ankle fracture or hip fracture, history of smoking, hysterectomy, hypothyroidism, diabetes, renal failure. These are all those conditions that should alert us to possibility of a red flag, which is a fracture. Now, to give you an idea, I have a little picture on the right-hand side. You see this bad habit of many doctors of giving oral steroids to patients. You see the oral steroid intake increases the risk of fracture by 2.6 times. Another aspect of that is, you know, how all these hip fractures, for example, that are taken care of in the hospitals or ASCs by total hip replacement or nailing, only 20% of those patients in 1 year get evaluation of their bone health. So that tells you part of the problem why these are undiagnosed. Now, a lot of times, unfortunately, many primary care settings will rely on an X-ray. Unfortunately, 42% of even those symptomatic fractures don't have a collapse on the X-ray. So every now and then I'm going to tell you this is a phrase, take-home phrase, and this red one is one of those. Remember, not every fracture has compression, but every compression is a fracture. So in order to further the diagnosis, you always need to have evidence of edema in the bone, and you can achieve that either by MRI or bone scan. Next one, please. Now, why do we treat these? Why all these societies and groups, they all push for early treatment of these patients? Because so-called conservative therapy has a huge impact on the health of these individuals, and a negative impact. And I have a list of this, but most importantly, every week that you are in bed rest, you lose 2% of your bone mineral density. 2% per week, remember that. Every fracture reduces forced vital capacity by 9%. As a result, you will have atelectasis, less effective coughing, part of it because of the pain when you cough or take a deep breath. And usually these will result in pneumonia, and that's how most of these patients will die. Bed rest, DVT, there's 61% of them will get the DVT, and then 2% will have a PE. Out of that, 0.5% to 10% will be fatal. And then this list goes on and on. You know, it's very typical that these patients are placed in bed rest and nursing home, and a duragesic patch is placed. So they get constipated, they lose appetite, they become depressed, they become anxious, they develop decubitus ulcers and stones. So I have this phrase from multiple societies that mentioned, this is from a few years ago. They said, although conservative implies safe, but conservative therapy is neither benign nor risk-free. And these are some of the complications. Next one, please. So one of the things that we rely on for diagnosis of osteoporosis is bone Dexa. And as you know, when you have osteopenia, the risk of fracture doubles. If you have osteoporosis, the risk of fracture quadruples. Now, one of the problems with relying with Dexa, and some of you who treat these fractures have definitely come across, is that you will have falsely elevated bone density on the Dexa scan. Patients, we have severe degeneration in their spine, or they have compression fracture or vascular calcification. So what do you do? How do you document? How do you establish medical necessity, which is important whenever you do any procedure? So one of those techniques that has been described, and this could be if the patient has had a CT of their lumbar spine, you can just ask your radiology colleagues to go to the PACS system and then do this Hounsfield unit measurements. And they're usually, they do it at L1 vertebral body, at mid-sagittal level. They do 3 measurements, and usually any level below 135 will be osteopenia, below 110 will be osteoporosis. So that's a good way of compensating for lack of Dexa, bone Dexa specificity. As you can see, this one is 90% specific. Next one, please. So if the question on your mind is whether vertebral augmentation works or is it safe? My answer will be heck yes. Remember, the goal of this treatment, the goal is to reduce pain, improve mobility, and prevent the consequences of kyphosis and immobility that we discussed before. Who are the target patients? The target patients are those who have significant pain. Some payers have a cutoff of 7 out of 10, and immobility due to either acute or subacute pathological fractures. Pathological means either osteoporotic or metastatic. Next one, please. So yesterday when I did a quick search, I came across over 6,600 indexed articles on these two treatments, vertebroplasty and kyphoplasty. So when we talk about literature, this is very significant number. And there is some studies with huge numbers, and I will allude to that later on. But this was this is a very nice review. You will see some of our colleagues as authors of this International Society for Advancement of Spine Surgery. They did a very nice review about the indications, limitation, and more important, medical necessity. I'm going to read this to you quickly. This will be one of those take-home messages that is advocated by this society, that these procedures are safe and effective procedures that have been highly studied. This is not 1 or 2 studies with 50 patients. The level 1 evidence is overwhelmingly in favor of augmentation when compared to so-called conservative management. And failure to treat them with these treatments results with increased mortality and morbidity. And they endorse these treatments, but not any specific technique or company. Next one, please. So this is another very nice review by our esteemed friend, Doug Beal, who shared some of these slides with me, and basically said that based on level 1 and 2 studies, balloon kyphoplasty had significantly better pain reduction than non-surgical management, and slightly better than vertebroplasty. Next one, please. Now, one of the findings of his review was that basically the better restoration of the kyphosis means better clinical outcomes. And that's when the volume of cement actually does play a role. In the old days when we used to do this, me and Ricardo started doing this 18 years ago. And we didn't care how much. And we used to say, you know, it's not how much you inject there that results in good pain relief. But based on recent literature, the amount of cement injected does affect the outcome. Next one, please. So this is a big list of all the level 1 and 2 articles published on vertebral augmentation. Next one, please. This is a better way of showing this. This was again made by Doug Beal, and you can see obviously green is the good color and red is the sham against the vertebral augmentation, that there are no studies basically. So as you can see, green has abundance of evidence here. Next one. That's why I say heck yes. So that's about the efficacy of it. You can go read this. I'm sure these slides will be available. And how about the mortality and morbidity? So when you come to discussing the complications and morbidity of a treatment, you know, you need large numbers. And look at the amount of literature here, the number of patients that have been reviewed. And it's almost 4 million patients that were followed anywhere from 3 to 10 years. Next one, please. Now, this is a slide that if nothing you take home from this talk, this will be the one that you need to remember. And anytime patient tells you, or anybody, many of our colleagues will tell you that, you know, this doesn't work, doesn't help patients, remind them that when you compare the mortality in patients, this was done in over 2 million Medicare patients with osteoporotic fractures. They compared the ones who had been treated with surgical, meaning kyphoplasty, vertebroplasty, to those with non-surgical management. So at 1 year, those treated with balloon kyphoplasty, look at the mortality rate. Those who did not have the balloon kyphoplasty, they had 55% higher mortality at 1 year and 24% higher at 10 years. The numbers were also good with vertebroplasty, 30% higher at 1 year and 8% higher at 10 years. Now, this came out of a nice paper that was published a couple of years ago. They looked at all this data before those, I call them sham studies that were published in, unfortunately, in New England Journal of Medicine in 2009. And then they looked at the risk of death prior to those articles and after. And this is a number you need to remember. Based on all these numbers and all these lives that could have been saved, thousands of lives, every 15 procedures that you do in 1 year, you're saving 1 life. In 5 years, is every 12. So this is the importance of this procedure as far as, and when I say this is a procedure that saves lives, there is your data. This is based on huge, huge Medicare data. Next one, please. So this was also a nice paper that was a meta-analysis of 16 studies done by colleagues from Australia. It was published a few months ago in radiology. And basically, the conclusion was compared to non-surgical, meaning so-called conservative management, augmentation patients had 22% less chance of dying in 10 years. Now, one of the things that I would like to mention is that, unfortunately, you know, interventional pain doctors and societies have been kind of passive about this treatment. And thank God to our radiology colleagues who have always taken the lead in this treatment. And that's why this treatment has been basically saved. Next one, please. Now, is this cost effective? Obviously, this was also extracted from the same paper by Ong that looked at over 2 million Medicare patients, and average vertebroplasty cost at 2 years was $44,000. Kyphoplasty was $41,000. You might say, how come vertebroplasty cost a little bit more? And it was because of the higher, basically better success rate, slightly better success rate with kyphoplasty, resulting in less medical utilization by those patients. Next one, please. Okay, so this is another one of those procedures that Ricardo and I loved it from the get-go, and we have been doing, I did one today. So we used to call it sacroplasty. There was a T code for it. And thank God to the efforts of our radiology colleagues, about 3 years ago, CMS decided to add, to change the concept to lumbosacral vertebroplasty. So vertebroplasty, it's either thoracic, or instead of lumbar, they call it lumbosacral. So you can use the same code for lumbar vertebroplasty to do this procedure. And as you can see on the left side, that's the whole body bone scan, and that's called the Honda sign or Hummer sign, whatever you want to call it. That's very specific to insufficiency fractures of the sacrum. I had this patient that for years we have been doing SI joint injections and then facet injections, radiofrequency, and he used to do real well. And then recently, none of them were working. And then it dawned to us that, oh boy, he has chronic kidney disease. And these patients, you know, are known to have osteoporosis. Lo and behold, we did the imaging and he had bilateral sacral insufficiency fracture and ended up going home in good spirit today. Next one, please. So recently there has been some newer inventions as far as implants that help with basically restoring the height in vertebral bodies. And these implants are left in place, and they had a nice study against the kyphoplasty with slightly better outcomes and less adjacent level fractures. Next one. Now, I'm gonna end up on this note that, you know, we need to pay attention to patients with cancer. You know, Peter had very good point in the beginning. You know, some of these patients we ignore, we don't pay attention to them. Like Mark was talking about the hip or knee surgeons. So cancer is a reality. There is 60 to 80% of cancers, they eventually result in metastatic bone disease, and some of those end up fracturing, and you need to be aware and high level of suspicion whenever a patient has history of uterus, lung, breast, prostate, liver cancer. You should always look for red flags. Next one, please. So what do you do with these patients? This is one of those things that you can do. There's different, you know, vendors for this. This is the one that I have used, and it's called OsteoCool. Basically, you deliver cooled radiofrequency in a bipedicular fashion to the tumor, and for about 14, 15 minutes, and then you take the probes out, and through the same trocar, you do your balloon kyphoplasty and fill it with cement. Extremely rewarding, and usually the younger patients, and it does help them with quality of life. There's a YouTube, if you search for OsteoCool on YouTube, you will see a patient testimony that, you know, it will bring chills to you. All right, next. I think we're done. All right, on that note, we'll take questions, I guess.
Cool. Well, thanks, Ramson. Excellent presentation for such an important topic. We're running a little bit over, but there is one question that's out there for you. With respect to the amount of cement injected, does it change when we consider a newer cement such as Stryker's Cortos?
Well, Cortos was interesting. We were in the study, believe it or not, and a very nice interdigitation, and then against the other treatments at that time showed less adjacent level fractures. But the problem is the cost of it. And that's the one factor that prohibits us from that. But the current cements that, all these big vendors have, they're pretty good. We don't have an issue. And, usually, well, even if you're in the lumbar area, 4 or 5 ml is gonna be an adequate amount.
Excellent. So the answer was, it came in from Anonymous. And so I'd love to know who Anonymous was on that previous question. It was Prithvi Raj. Prithvi Raj was the person who figured that all out. So he's now passed away, but just a legend in our field. Many of us still have his books out and around for studying. Let's see, can we go to the next slide, please? Our next event is going to be October 20th. So it's 2 weeks away this time. And then following that, I think I've got it set for November 3rd. We also have we're planning an in-person meeting right now, God willing, with this COVID virus for April 20th. So plan your schedules, April 23rd to 25th, 2021 in Pentagon City. And we'll be, this is planning on being our Board of Physicians. You have to go within 48 hours here to get your live credit. And here's where you go to get it. I'll leave that up there for a second. Or maybe, Michelle, we can email this one slide out to people about how to claim their credit. So you have to get it within 48 hours to be able to get this. With that, if anybody's interested, I'm going to be doing a webinar on Thursday with Secretary Shulkin about various aspects of happening with COVID. Email me directly and I'll send you an invite to the webinar, 3 p.m. Eastern time, noon Pacific time. Secretary Shulkin and I are going to do a 20-minute conversation around new things, new treatments for COVID. And I probably will get into some of the new findings that about nerve pain and other things that are going on right now, looking at what we're finding long-term effects of COVID. So just send me an email if you're interested, and I'll make sure you get an invite to the webinar. With that, I'm going to release you all to go home. Congratulations, Anonymous, for knowing Prithvi Raj. Congratulations to Dr. Patel. You too are getting a backpack, and Dr. Benjamin. Kevin or Corey or Bill should be sending that to you. Let me know. I will need to get your home address so we can drop that in the mail. Thanks, guys. Have a wonderful night, and we'll see you in a few weeks. Please send me ideas on new topics and new speakers.
Thank you.
Thanks, guys.